Okay. All right. So this evening we're going to look at premature beats. First, we're going to look at premature atrial contraction. We call it also supraventricular uh, premature beats. We're also going to look at ventricular premature beat and how to distinguish between the different premature beats. Okay. So when we say a premature beat, that means it comes early. So anything that's premature, comes a little bit earlier. So when we say a premature atrial beat or premature atrial contraction, that means an atrial beat comes a little bit earlier. And on the surface ECG, you have to be able to distinguish between what we call a premature atrial beat or premature atrial contraction from a premature ventricular beat. Okay, when you look at the surface ECG, you need to be able to distinguish them. One of the distinguishing feature is uh, looking to see if there's a P wave. Okay, usually when you have a premature uh, atrial beat or premature atrial contraction, there is a P wave. Okay, however, the P wave is going to look different from the intrinsic P wave. That is the regular P wave. The QRS is going to look normal, so it's not going to be wide and bizarre. It's going to be narrow usually, and it's going to have a P wave before the QRS. But the P wave is going to be different from the intrinsic, the normal P wave, and this is what it looks like. So this is a normal beat. Okay, so this is a normal beat. Um, you can see you have the P wave followed by your QRS. Okay, this interval, this R wave to R wave, is the normal interval. So this R wave to this R wave is a normal interval because usually the heartbeat is regular. But if you look on these two beats, they come a bit early. They're early. So this beat is a bit early, but it has a P wave in front of the QRS complex. And if you were to look closely, I mean, this P wave looks similar, but they're usually different. Okay, the QRS is narrow. It looks just like the intrinsic QRS, and the QRS is as a P wave in front of it. So this is a premature atrial beat or premature atrial contraction. Okay, so the complex is early because this is the normal R to R interval. So you expect the other beat to come someplace about there, but it's a bit early. Okay, there's a P wave in front of the QRS, and that makes it a premature atrial beat. Okay, what happened? For some reason, the atrium is stimulated, and when the atrium is stimulated, the impulse travels down the atrium to the AV node, the bundle of hairs, and the bundle branches and stimulates the ventricle. So you're still going to get a ventricular complex, QRS, but the whole thing is going to come early. And the QRS is going to look similar to the intrinsic QRS. Okay, so these are premature atrial beats. When we talk about premature ventricular beats now, that means a beat is a beat originated in the ventricle and it came a bit early. So this doesn't project very well. It's very light, but look at the bottom of the rhythm strip. You have P, QRS, P, QRS, P, QRS, and it repeats itself. The R interval are regular, they're regularly spaced, and then this beat came early. This beat came early. But if you look at the beat, it's wide, it's bizarre. There's no P wave in front of the QRS. And the T wave is different from the intrinsic T wave. You see, the intrinsic T wave, the normal T wave is upright, whereas the T wave following this premature beat is inverted, and it's large, it's big. It just looks different. So when you have a wide complex beat that comes a bit early, you have to try and determine, is this a PAC or a PVCs? If you have a P wave in front of it, it's probably most likely a PAC, premature atrial contraction, premature atrial beat. But if you look at this premature beat, there is no P waves. It's wide and bizarre, and uh, we call it a premature ventricular beat or premature ventricular contraction. It's very important to be able to distinguish PACs from PVCs, because if you have 3 or more PVCs in a row, we call that ventricular tachycardia. And ventricular tachycardia is not a good thing. So you need to be able to distinguish your premature atrial and premature ventricular beat. Remember, this beat originates in the ventricle as opposed to your premature atrial beat, which originates in the atrium. So it originates in the ventricle, and whenever you have any beat that originates in the ventricle, it's going to be broad, it's going to be wide, it's going to be bizarre. Okay? So that is why if you have multiple premature beats looking like this, premature ventricular beats, it's ventricular tachycardia, because it's a tachycardia coming from the ventricle, which is usually bad. That's bad. All right. So again, ventricular tachycardia, the definition for ventricular tachycardia, remember what we said in our last session. When bradycardia is a rate less than 60, tachycardia is a rate greater than 100. The definition for ventricular tachycardia is if you have 3 or more PVCs in a row, and usually the rate is greater than 100. So this is a ventricular tachycardia. You can see the complex is broad, wide, and bizarre. So it's coming from the ventricle. And if you check the rate, remember we went over rate. To get the rate, it is 300 divided by the number of big blocks separating your RR interval. So there's about 2 big blocks separating, or less than 2 big blocks separating your RR interval. So this rate is well over 100 beats. And you have 1, 2, 3, 4, 5, 6, 7 of these beats. Well, it continues. So you have multiple of these beats occurring in a row. But the definition for ventricular tachycardia is 3 or more PVCs in a row. The rate is usually greater than 100 beats per minute. All right, so we looked at PACs, PVCs. Okay, now we're going to look at tachycardias. And anything above the AV junction we call supraventricular. Anything below the AV junction we call, anything below the bundle of His we call ventricular usually. All right. So when we talk about supraventricular tachycardia, it is a tachycardia, a rapid heartbeat, originating usually above the above the bundle of His. All right. So tachycardia that originates above the bundle of His we call supra. Supra meaning above, and tachycardia is fast. The most common supraventricular tachycardia is what we call AV and RT. And I mean, unless you guys want to go further, you just have to know that this is the most common. I'm going to explain it for those people who needs to know more about AVNRT. So AVNRT is the most common narrow complex supraventricular tachycardia, and it usually involves what we call a reentry circuit in the AV node. So what happens, and let me draw this. This is just for the people who needs to know this. This is, if you don't need to know this, then you just. All right, so what happened, again, we have the atrium up top, okay? And let's call this the AV node. We're going to draw the AV node as a circle, but yeah, okay? And let's call this the ventricle below here. So this is the atrium up top, and this is the ventricle. So we normally have our impulse coming from the atrium to the AV node. Okay, this is our AV node right here, and we draw it as a circle. So this is our AV node, AVN. All right, so when you have the impulse coming down the atrium, it usually comes straight through the AV node. It slows a little bit, and then it comes into the ventricle. That's our usual scenario. But some individuals have what we call a dual AV nodal physiology. Okay? Some patients have a dual AV nodal physiology. They have two pathways. They have a slow pathway and a fast pathway. We call the slow pathway the beta pathway. Okay? So the beta pathway is the slow pathway. And then the fast pathway is the alpha. Okay? So some people in life do have this dual pathway to allow impulse coming from the atrium to try. It can come this direction or it can go in this direction. If the conditions are right and you have a dual AV nodal physiology, what will happen is when your impulse, usually a premature atrial beat, will come here and it will find the fast pathway refractory. So it will travel through the slow pathway, which is not refractory. Okay, so the impulse will come down here and it will go into the ventricle. But once it gets to this point, it will find that this fast pathway now is out of its refractoriness. So it's able to transmit an impulse. So the impulse is going to go back into the atrium via this fast pathway we call the alpha pathway. So the impulse is going to go back into the atrium, okay? And when it gets to this point, it's going to find the slow pathway out of refractoriness. So the impulse is going to go round and round and round. It's going to stimulate the ventricle as well, okay? So this is what happens when you have AVNRT, AV nodal reentry tachycardia. A premature beat comes, it finds that this fast pathway is refractory, so it preferentially travels down the slow pathway, which is not refractory. When it gets down into the ventricle, it goes, but it also finds a slow pathway out of refractoriness. So the impulse go up, back, and then the slow pathway is out of refractoriness. So it goes round and round and round, and you get AVNRT. It's the most common narrow complex supraventricular tachycardia. And because the P wave, because this is the fast pathway, it transmits the impulse very, very quickly into the atrium. So whenever you stimulate the atrium, you're going to get a P wave. So what happens is the ventricular stimulation is almost at the same time as the atrial stimulation. So a lot of times the P wave is buried in the QRS, because when the impulse comes down here and stimulates the ventricle, this impulse rapidly goes to the atrium and stimulates the atrium. So the P wave is buried in the QRS, and you'll get something looking like this. Okay, so it's a very fast, narrow complex tachycardia, and usually the P wave is either just after the QRS or it's actually inside the QRS. And the reason for that is because the fast pathway, when the impulse gets into that down the bottom of the AV node, it's going to stimulate the impulse is going to go into the ventricle, it's going to stimulate the ventricle, it's going to rapidly go to the atrium and stimulate the atrium at the same time, sometime a little bit after. So if you see a P wave just outside the QRS, or sometimes it's buried in the QRS, it's usually what we call AVNRT, one of the most common cause of narrow complex supraventricular tachycardia. All right. So AVNRT is one of the most common supraventricular tachycardia. Tachycardia means fast. We're not gonna go into the difference, but anyway, you know, the common type or the typical type of AVNRT, the P wave is buried in the QRS or just comes after the QRS. And the uncommon type or the atypical type, the P wave is usually some distance from the QRS complex. All right, so again, only if you need to know this. Just remember that AVNRT is the most common supraventricular, narrow complex supraventricular tachycardia. All right, we look at that. Now, there's another type we call atrioventricular reciprocating tachycardia. It's another type. And again, only people who need to know this need to try and understand it. What happened is with AVRT, let me draw it. So again, if this is our atrium, and let's draw the AV node as a circle again. Okay, and this is our ventricle. So if this is your atrium, and this is your ventricle, and then this is your AV node. Sometimes you get what we call, let's label it AVN. AV, this atrioventricular AV node, atrioventricular node. Okay. Sometimes you'll have what we call a bypass tract. You'll have a bypass tract. A bypass tract is a specialized conduction tissue that connects, it bypasses the AV node and it connects the atrium directly to the ventricle. It's just like if you have a short circuit in the wiring of your house and you bypass they say you bypass a load or you bypass the power station. So this bypass tract, let's call it BT. It bypasses the AV node. So it connects the atrium directly to the ventricle. Remember, the design of the heart is not by random. The AV node is supposed to slow impulse traveling from the atrium going into the ventricle. Okay? Just imagine if you bypass that slowing, and this bypass tract can transmit impulse very, very quickly. Okay? Very, very quickly. So, if you have, say, any rapid heartbeat, the AV node usually protect you from the rapid atrial beat by slowing it down before it gets to the ventricle. And that is why when you have atrial fibrillation, it is not very dangerous unless you have a bypass tract, because the AV node, which is a protective design, slows some of the atrial beat going into the ventricle. When you have a bypass tract, you eliminate the AV node. So AVRT, what happened with AVRT? You get a supraventricular tachycardia that comes down the AV node the right way. Okay, it comes down the AV node the right way, but the impulse goes back up the bypass tract. Okay, so it returns to the atrium via this accessory pathway. So you get a re-entry thing again, because the impulse comes down the AV node, it gets the bypass tract out of its refractoriness, and then it travels up the bypass tract to the atrium. So you get something looking like this. So again, you know, for those who are doing just straight echo, you don't really have to know. So you can see that the complex is wide. So when, you know, the complex is actually wide, and this is AVRT, okay? So the impulse travels down the AV node, antegrade, and then retrograde, that is it goes back up the bypass track, and it's going to give you a wide complex tachycardia. Okay, AVRT. All right, it's not AV and RT. You know the difference. All right, now these supraventricular tachycardia are extremely common. So atrial flutter, and you know, you guys must have heard of atrial flutter. Atrial flutter is a supraventricular tachycardia, a rapid heartbeat coming from the top of the heart, and it usually originates close to the tricuspid valve. There's a little triangular area there that the impulse usually originates, and the atrial rate. So it is a spontaneous firing. Okay, another reentry mechanism. The atrial rate, that is the atrium usually fires, or well, the atrium contracts at about 250, 300, or 400 beats a minute. This is the usual atrial rate for atrial flutter. Again, remember, the AV node is protective. If you didn't have the AV node, and all of this 250 or 300 beats goes into the ventricle, you'll be dead. Okay? But again, remember, the heart was designed in such a way that it's going to slow the impulse that's coming from the atrium. So when you have an atrial rate of, say, 250 to 300 beats per minute, the ventricular rate will be a variable of this. The AV node usually blocks the atrial rate in a ratio of, say, 2 to 1, 3 to 1, or 4 to 1. That is, out of every 4 beats, it will allow only 1, or every 3 beats, it allow only 1, or every 2 beats, it allow only 1. It's a protective mechanism, okay? To diagnose atrial flutter, okay, again, we said the atrial rate is usually between 250 and 350 beats per minute. And the typical atrial flutter, you get what we call a negative sawtooth pattern in leads 2. And when you look in lead V1, it's going to be upright. So this is what atrial flutter looks like. All right. Yeah, this is what atrial flutter looks like. All right. So if you look at the rhythm strip, so you know this is your 12 lead ECG. Just look at the bottom where we just continuously look at one lead. We select lead 2 and we just continuously play it. you can see that these are negative. They go below the baseline, and that's what we say negative. When we say it's negative or positive, if it's negative, it's below the baseline. If it's positive, it's above. In lead 2, you get negative sawtooth pattern, and each of these little umps or lumps or whatever you call them are P waves, and you can check the atrial rate. You can see that the number of big blocks separating each of these little lumps, and they're regularly spaced. So with atrial flutter, these little bumps are regularly spaced, okay? Regularly spaced. And you can see the number of big blocks between each of them is about one big block. So we know that if we divide 300 by 1, 300. So the atrial rate here is about 300 beats per minute. Okay? And if you look in lead V1, you can see that these little humps are now upright. Okay? So this is what we call typical atrial flutter. Negative sawtooth pattern in leads 2 and positive sawtooth pattern in V1. Typical atrial flutter. Okay? You can see that the ventricular, remember the QRS represents the ventricular response. The ventricular rate is irregular because the AV node is protecting the individual, because the AV node is not going to transmit one-to-one. The AV node is going to slow the atrial flutter or the atrial tachycardia. Okay, it's going to allow it probably 4-to-1, 3-to-1, 2-to-1. This is what we call atrial flutter with variable AV block. So there's not a fixed pattern. It's not 4-to-1, because in this one it is 1, 2, 3. In this one it's 1, 2. This is 1, 2. This is 1, 2, 3. So it's variable. So it is atrial flutter with variable AV block, as opposed to this, where if you look closely, just usually when you're doing rhythm, you just take a rhythm strip. So we usually look at lead 2 and we just look at it. So you again, negative sawtooth pattern in lead 2, okay, and it's positive in V1. That's typical. But anyway, you can see this is a P wave, this is another P wave, that. You can check the atrial rate, okay? So from P to P, it's a little bit more than one big block, so the atrial rate is less than 300 beats per minute, okay? But for every 2 P wave, you have 1 QRS. 1, 2, 1. 1, 2, 1. 1, 2, 1. So for every 2 P wave, you have 1 QRS. So this is what we call atrial flutter with a 2-to-1 AV block. That is, the AV node is blocking every, it allows only 1 out of every 2 beats to be transmitted. It blocks every other beat. So if the atrial rate is, say, 300 for argument's sake, the ventricular rate is going to be 150. And if you look here, from R to R is about, two big blocks. So the ventricular rate, which is R to R, is about 150, the number of big blocks separating it. Whereas the atrial rate, P to P, is about 300, roughly. We're not going to be, all right? So this is atrial flutter with 2-to-1 AV block. All right. Now, if you see this, you're in trouble. Okay. This is atrial flutter with a 1-to-1 conduction. It's not supposed to happen, but it does happen. I've seen a couple of patients with it, and these patients will collapse right in front of you because the heart, If you look here, the heart rate is about close to 300 beats a minute, R to R. Okay, heart rate is 300 divided by the number of big blocks separating the R to R. These patients will collapse. They will have no blood pressure right in front of you. Okay, you have to get them out of it ASAP. So, you know, if they're in it and they're hemodynamically unstable, blood pressure is low and stuff, you have to shock them out of it, okay? And you have to send them to get ablation. You have to get rid of this atrial flutter, okay? So, but it doesn't, it rarely happens, okay? Because remember, the AV node usually slows. That's the function of the AV node. All right, atrial fibrillation. So atrial fibrillation is the big brother to atrial flutter. Atrial fibrillation is a very common arrhythmia, and you have, whenever you see this, you have to be able to identify it. With atrial fibrillation, the electrical impulse usually originates in the root of the pulmonary vein. And you remember you have 4 pulmonary veins. So these electrical impulse usually originates in the root of the pulmonary veins. And the electrical impulse, so it's just going to fire spontaneous. You're going to get spontaneous firing. Usually, we talk about the rate of firing is about 400 to 600 times a minute. Okay, 400 to about 600 times a minute. That's what these electrical impulses are firing at. Okay, usually located around the root of the pulmonary veins. Again, the AV node is protective, so it's only going to allow a few of those beats, because if the AV node wasn't there and you have 400 to 600 beats in the atrium, all of that would go into the ventricle. The patient would be dead within a couple of minutes. Okay, so you get, with atrial fibrillation, you'll get an irregular ventricular response or irregular ventricular conduction because of the AV node. The AV node is going to slow a lot of these atrial beats. When you look at your ECG or EKG, there will be no discernible P wave. You get an irregular baseline. And we usually refer to the arrhythmia or the rhythm as irregularly irregular. Okay? Irregularly irregular. So this is what atrial fibrillation looks like. Again, let's just take out a rhythm strip. We look at lead 2 and we just play lead 2 all along. Again, you're going to get your 12 lead EKG, all right? But when you look at the rhythm strip, we just take it out and we'll play lead 2 continuously. You get your QRS, T wave, no P wave. QRS, T wave, QRS, T wave. So the baseline, where the P wave is supposed to be, you'll see little undulation, what we call flutter wave, but you're not going to see any discernible P wave. There is no discernible P wave. And when you look at your R to R interval, it's irregularly irregular. There is no regularity to it. Every beat is different. The interval is different. Every beat, the interval is different. Okay? There is no fixed interval. Every beat, the interval is different. So when you get a 12 lead EKG like this, where you have the R to R is irregularly irregular, there's no regularity to it, and there's no discernible P wave on the baseline, and you probably get fibrillatory waves. Okay, there's no organized P wave. With atrial flutter, you're gonna get very distinguished P wave. atrial flutter, you get very distinguished P wave. They're gonna be down, they're gonna be down, they're gonna be negative or displaced downward uh, in lead 2, but there you can see they're well organized and they're regularly spaced. As opposed to atrial fibrillation, you have no discernible P wave, none at all, no discernible P wave. The baseline is wavy. You might see little humps and lumps right there, but it's not regular, okay? And then when you look at the R to R interval, it's irregularly irregular. Irregularly irregular, okay? So irregularly irregular beats suggest atrial fibrillation, okay? All right, so we talk about atrial flutter, atrial fibrillation. Let's go to ventricular tachycardia in a little more detail. So again, as we said, the classic definition for ventricular tachycardia is 3 or more PVCs in a row. The rate is usually greater than 100 beats per minute. And of course, these arrhythmia originates in the ventricle. That is why they're called ventricular tachycardia. And again, the heart rate's supposed to be greater than 100 beats per minute. But we have what you call sustained and non-sustained ventricular tachycardia. It is sustained if you have these PVCs all in a row lasting for more than 30 seconds. So if it lasts more than 30 seconds or you have more than 30 PVCs in a row, this is what we call sustained ventricular tachycardia. If it lasts less than 30 seconds or there are less than 30 PVCs in a row, it is a non-sustained ventricular tachycardia. This definition is very important. But once you have 3 or more PVCs in a row, that's ventricular tachycardia. And remember, the QRS is going to be wide and bizarre, but the R to R interval is going to be regular. The R to R interval in ventricular tachycardia is going to be regular. So if you see a patient, you know, wherever, and they have these wide, bizarre P waves all in a row, I mean QRS all in a row, and it's very regular. It's probably ventricular tachycardia. Okay. So again, remember, it's very important to make your diagnosis of ventricular tachycardia, because these patients, a lot of these patients don't do very well, and you have to treat them urgently, okay? As opposed to your supraventricular tachycardia. So this is what your ventricular tachycardia looks like. Just as good as the rhythm strip, you can see it's very regular. The distance between the RR is sort of fixed. Okay, wide, bizarre tachycardia. You can do the rate about two big blocks separating the R to R interval. So the rate is about 150. So 300 divided by 2 is about 150. Wide, bizarre tachycardia. Okay, and if it's sustained, it lasts more than 30 seconds. If it's non-sustained, it lasts less than 30 seconds. Ventricular fibrillation. This is a terminal rhythm. What we mean by terminal rhythm, if nothing is done, you're gonna be dead. Okay? This is most people when they die, or a lot of people when they die from ventricular fibrillation. It's a terminal rhythm. Okay, if nothing is done, you will die. So ventricular fibrillation, you get these uncoordinated contraction of the ventricle. So just, you know, the ventricle quivers. It quivers. It probably beating 600 or more times a minute. So if it's going to be 600 times a minute or more, it quivers. It quivers. So it's not contracting. Remember, the heart, the normal function of the heart is to contract and pump blood throughout the body. If the heart is quivering, the brain is not going to get any blood. And if the brain doesn't get any blood within 10 seconds, uh, you know, the patient will start having problems. And within 3 minutes, if nothing is done, patient will die. Okay. So this is what ventricle. Just look at the rhythm strip. So if you see something looking like this, make sure it's not artifact, because artifact. So if you see something like this and the patient is talking to you, don't shock the patient, please. Okay. So use common sense a little bit, you know. So a artifact can also give you something looking like this. Okay. But if the patient passes out and you have something like this, the only treatment is to shock the patient. This is ventricular fibrillation. You can see that these are not coordinated impulses. They are all over the place. They're very, very rapid, okay? And the heart quivers. The heart is not contracting. So the only treatment for this is to shock the patient. All right. All right. So we finish with tachycardias. We're gonna go on to blocks. So the impulse, again, these are just electrical stuff. So when we do electrocardiogram, it's just the electrical uh, activity of the heart and what can happen uh, to the electrical stimulation. When we talk about AV block, that means you have the impulse going from the atrium to the ventricle is blocked. Okay, and there are different types of AV block. So when we talk about AV blocks, atrioventricular blocks, the impulse, electrical impulse going from the atrium to the ventricle is blocked. The first one is what we call first degree AV block. That is, the impulse takes a little bit longer to travel from the atrium to the ventricle. So when you look at your PR interval, remember when we just started our ECG, we talk about how to measure PR interval. PR interval is from the beginning of the P wave to the beginning of the QRS. Okay, that is your PR interval. If it's more than 200, and some text will say 210 milliseconds, then you have first degree AV block. So first degree AV block if the PR interval is greater than 200 milliseconds. So you have to measure it. It just means that the impulse going from the atrium to the ventricle is slowed. And so you get your 12 lead EKG. All right, you know how to read EKGs now because sinus rhythm means you have upright P waves in leads 2, 3, and AVF. Okay, so lead 2, 3, and AVF, the P waves are upright. So it's a sinus rhythm. But when you check your PR interval, this is much greater than 200. Remember, one big block is 200 milliseconds. One big block is 200 milliseconds. The little tiny blocks are 40 milliseconds. And you have 5 of those tiny blocks in a big block. So the big block is 200. So your PR interval is from the beginning of the P wave to the beginning of the QRS, and you measure it. If it's greater than 200 milliseconds, you have first degree AV block. All right. Now you can have second degree AV block. It's just this is now a more advanced type of block from the atrium to the ventricle. It's a more advanced block from the atrium to the ventricle. When you have second degree AV block, there are two types. We have second degree AV block type 1, and we have second degree AV block type 2. The second degree AV block type 1 is what we call the Mobitz 1 or Wenckebach. Second degree AV block is a more advanced AV block than first degree AV block. There are two types of second degree AV block. You have type 1, we call that Mobitz 1 or Wenckebach. And when you look at second degree AV block type 1, when you look at the PR interval, it progressively prolongs, and then you have no beat at all. Okay? So the PR interval gets progressively longer and longer, and then you have no beats. Let's look at the rhythm strip. So you always look at the rhythm strips, and let's look. So read 2 is a good rhythm strip to look at. So when you have group beating, this is a very common cause of group beating. So you'll have, rapid beating, slow. So all right, let's analyze this. So this is a rhythm strip. The P wave is right there. Or PR interval is from the beginning of the P wave to the beginning of the QRS. So you can see this PR interval is prolonged. You have your QRS, you have your T wave, you have a P wave and no QRS. Okay, so you have a drop beat. You have a P wave but no QRS. Okay, then you have your P wave. It has a certain length to it. You have your QRS, you have a T wave. Then you have the P wave, PR interval, and your QRS. If you look closely, you can see that this PR interval is a little bit longer than this one. And you can measure it, but this PR interval is longer than this one. So we have our QRS or T wave, P wave, QRS. This PR interval is a little bit longer than this one. Okay? We have our QRS, T wave, P wave, PR interval, and our QRS. This PR interval is longer than the one before it. Then you get your QRS T wave. They get a P wave, no QRS. This is classic second degree AV block type 1. Progressive prolongation of the PR interval, and then you have a drop beat. You have a P wave but no QRS. Okay? This is telling you that there is some disease in the AV node. The AV node is disease. So not every beat is going to transmit to the ventricle. Okay? So you're going to get progressive prolongation of the PR interval, and then you get a P wave, no QRS. Usually with Wenckebach or type 1, second degree AV block type 1, usually the PR interval after the drop beat is the shortest. So this is our P wave, we have no QRS. And then our P wave, PR, QRS. So this is the P wave after the drop beat, and the PR interval is usually shortest. Then it starts lengthening again. The PR interval starts lengthening. And then you have a P wave with a drop with no QRS. So this is classic second degree AV block type 1. It's a more advanced AV block. Then you have second degree AV block type 2. So Mobitz 2. So remember we said with second degree AV block you have two types. You have type 1 and type 2. With your second degree AV block type 2 or Mobitz 2, the PR interval remains unchanged. It remains constant, but you just get a drop beat. So let's look at the rhythm strip. Let's look at lead 2. Lead 2 is a very good rhythm strip to go to. So you have your P wave, your QRS. Then you have another P wave. You have your another P wave, QRS. You have P wave, QRS. So what you're getting these P waves. So this P wave have no QRS. This P wave have a QRS. Remember, when the atrium is stimulated, the normal the natural thing is for the impulse to travel through the atrium, slow in the AV node, and go to the ventricle. That didn't happen here. So you have these P waves, but no QRS. So this is what we call second degree AV block type 2 or Mobitz 2. Okay, there's no PR lengthening. You just get a drop beat. Okay, the PR interval is usually unchanged, but you just get a drop beat. So this is a more advanced form of AV block than your type 1. Then if you have second, you're going to have third. Okay, so our third degree AV block is the most advanced of your AV blocks. Third degree AV block is the most advanced of your AV block. And we call this also complete AV block. So what happened, the impulse that is generated in the SA node, remember that impulse are in a normal individual, the impulse is generated in the SA node. So the impulse that is generated in the SA node and the atrium does not propagate. It does not go to the ventricle. The atrium is doing its own thing and the ventricle is doing its own thing. There is no communication between the atrial impulse and the ventricular impulse. Each chamber is doing its own thing. This usually occurs if you have a very sick AV node, or you can have the block below the AV node where no impulse from the atrium gets to the ventricle. So the heart is set up in such a way that if the ventricle is not getting any impulse from the atrium, it's gonna do its own thing, because the ventricle have specialized conduction system as well. So it usually waits on the atrium stimulation, but if the atrium does not stimulate it, it's gonna get its stimulation from what we call a subsidiary pacemaker. So with third degree AV block, the atrium is gonna send out an impulse. The atrium is gonna contract, but nothing can go to the ventricle. So a subsidiary pacemaker in the ventricle, we call, and it could be the AV node, or it could be a pacemaker, one of the conduction system below the AV node. So you're gonna get an escape rhythm. It was waiting for the atrium to do something. The atrium fires, but it couldn't get to the ventricle. The ventricle thinks that it's not going to get any stimulation from the atrium, so it comes up with an escape rhythm, okay? Because it also has its own electrical circuitry. So it will come out with an escape rhythm. The problem, however, is that usually the escape rhythm from the ventricle is very, very slow. The SA node usually fires between 60 and 100 times a minute, and that is adequate to make people feel good, then feel normal. The escape, or the rhythm that is going to come from the ventricle or the AV node, is usually about 40 beats per minute or less. It depends on where the block is located. And usually you're going to feel crappy, you're going to feel sick if that's your heart rate. So when you have third degree AV block and there is no communication between the atrium and the ventricle, and the ventricle decides to fire using its subsidiary pacemaker, that rate is only going to be 40 beats per minute or less. So that's an escape rhythm. So you have two independent rhythms. When you look at the EKG, there are two independent rhythms. There is no association between the two rhythms. Remember, when we talk about a normal ECG or a normal function of the heart, we have atrial contraction, we have a delay in the AV node, then we have ventricular contraction. When you have third degree AV block or complete AV block, none of this is operational. There is a complete independent rhythm from the atrium and ventricle. So the P waves are gonna be regular because the atrium is gonna fire constantly. So you're gonna see P waves at a regular P to P interval, but they're not gonna be any PR interval because there's no communication. QRS complex is gonna be regular as well because the ventricle is gonna be regular. So when you look at your R to R interval, it's going to be regular, but there's no communication with atrium, so you're not going to get any PR interval. When you look the PR interval, what you call the PR interval is going to vary. There's no, we know that in a normal patient, the PR interval is supposed to be fixed. So there is no relationship between the P waves and the QRS. So a third degree V block is going to look like this. So let's look at the rhythm strip. So lead 2 is so again, so these are your P waves. So you have to know what your P wave look like. So this is a P wave. This is a P wave. Trust me, this is a P wave is inside this T wave. This is a P wave. This is a P wave. P wave. P wave in the T. P. 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 When you map it out, the P waves are very, very regular. Okay, and you can get the atrial rate. Okay, so the number of big blocks between a P and a P is about 3. So the atrial rate is 300 divided by 3. So it's about 100 beats per minute. So the atrium is firing or contracting at 100 beats per minute. But there's no communication. You can see that there's no PR interval. If you call this the PR interval, it's different from this one. It's different from this one. Different. So there's no communication between the atrium and ventricle. So there's no PR interval. Let's look at our ventricular response. The R wave are from the ventricle, right? So this is an R wave. This is another R wave. This is an R wave. This is an R wave. This is a R wave. If you check this ventricular rate, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. We have 11 big blocks between our interval. So the ventricular rate is 300 divided by 11. It is less than 30. This is what I'm saying. When the ventricle didn't get any signal from the atrium, it's going to fire. But the ventricular or the AV node or anything below the AV node is going to fire at a very slow rate. This is slower than 30 beats per minute. So this is what your third degree or complete heart block looks like. Atrium is contracting independent of the ventricle. The atrial rate is regular. The ventricular rate is also regular, but there's no communication between the atrium and the ventricle. So this patient would be treated with a pacemaker. Okay, this patient would need a pacemaker. So we're gonna stop here, and our next session we'll do heart attacks. Again, you need to go over the lecture and try and understand what's going on. Okay, all right, so